Hefter Research Institute. We talk about MAPS a lot because they're so active in the social world, but we don't often talk about Hefter, that's less active socially or culturally, but very active in a research perspective. And the Hefter folks are all psychiatrists and neuroscientists, and they have also been funding wonderful research, including the Johns Hopkins, the NYU, and the first of the three was the UCLA group, and that's where Alicia is based. Alicia Danforth, PhD, is a researcher at the at the Los Angeles Biomedical Research Institute at the Harbor-UCLA Medical Center. Her work as a study coordinator and co-facilitator on Dr. Charles Grob's clinical trial with psilocybin for existential anxiety related to advanced cancer inspired her to become a licensed clinical psychologist. She attended the Institute of Transpersonal Psychology, where she co-developed and taught the first graduate level course on psychedelic theory, research, and clinical considerations for therapists and research and training. Her dissertation research was on the MDMA experiences of adults on the autism spectrum. She also specializes in mindfulness-based psychotherapy, trauma treatment, and psychedelic harm reduction at festivals and events. So I turn you over to the very capable hands of Alicia Danforth.
So his name has already been mentioned several times here today, but I'd like to start by telling everyone how much Dr. Charles Grob, or Charlie, wished he could be here today with everyone. This is his idea of a good time, but other travel commitments prevented him from being here today. But in lieu of his physical presence, let's just take a moment to acknowledge the groundbreaking work that he did to open quite a few doors into clinical research. He's worked with MDMA, psilocybin, and ayahuasca, and I just want to pause for a moment to express some gratitude for his persistence over many decades. Today we're going to be talking about current research exploring MDMA-assisted therapy for social anxiety with autistic adults. A brief disclaimer, no conflict of interest to declare. This is primarily a MAPS funded or sponsored study. We've also received additional funding from the Betsy Gordon Foundation and from a generous private donation. So for this study, we took a somewhat unusual step of publishing a paper last year about the rationale and method for this study, because from the inception, there were misleading headlines hitting the press about how ecstasy may soon be a cure for autism, and we were concerned that messages that might actually be harmful for the autism community might be spread, and we wanted to clear up several key misconceptions. So if you're interested in the fine details, I refer you to this paper. A bit more about the rationale. First, why are we working with autistic adults? I'm frequently challenged about why we're not serving the broader population. Autistic adults make up about 1% to 2% of our population here in the United States. We're not treating autism. We're treating social anxiety. That's a very important distinction to make when you're speaking with people about this research. The population we're working with, by definition, is challenged socially. Social anxiety is very prevalent with this group, but contrary to the way we're accustomed to speaking about autism, it's not really a linear spectrum. There isn't really this place in the middle of this spectrum where one can be a little bit autistic. Everybody inherits their own unique genetic neurocognitive variation that makes up their expression of autism. So the people that we work with have autism that might not be readily apparent when they first walk in the room. However, they're still expected to understand social norms. So as you can imagine, that's quite a recipe for social anxiety. A little bit of the science behind why this might be the case. Research has shown atypical inhibitory response, atypical oxytocin utilization, and atypical serotonergic transmission in autism. For this and other reasons, pharmacotherapy is often ineffective. It's not uncommon for us to hear in the past, I was on this, and that drug, but nothing really worked well for me. And as part of a doubly difficult challenge for them, psychodynamic psychotherapy or conventional talk therapy has not been shown to be particularly effective with this population. I've had individuals tell me that they were in therapy for several years and then wondered why they were coming to an office every week to explain to someone what it's like to be autistic. So this talk is going to be somewhat in two parts. I'm going to start with a little background on the qualitative foundations for this study. In the beginning, the approach was very feminine, very qualitative, very bottom-up, and very inductive. As a result, some of the early conceptions about what we should take as our clinical approach began in the form of images and analogies. And to give you a sense of how that emerged in the data from subjective qualitative interviews, we heard people describe the music of socialization. Or another example would be describing socialization as very qualitatively different when one approaches it like solving a mathematical problem. You know, if someone extends a hand, you do this, and these are the rules, as opposed to hopping on and riding a bicycle and seeing where it takes you. So in analyzing, applying thematic content analysis and continuing to deepen the qualitative approach, several key themes emerged. I call them the 5 C's. We had courage, communication, connection, communion, and clarity. And if you attended the Psychedelic Science 2013 conference, you got to see a very qualitative, heavy presentation that just worked the Wizard of Oz analogy for all it was worth. But we're at a very transitional stage now. The last group that spoke talked about applied versus basic science. And this is where the dance of the qualitative begins to meet up with the directed march of basic science. So at this juncture, after we got to know our population, we started to hone in on how can we bring in masculine approaches towards being more goal-directed, lining up particular tasks and applying the scientific method that will help us to address the social anxiety that was frequently mentioned in the interviews. So putting on the clinical hat and thinking, how do we apply what we've learned from these feminine, more qualitative approaches in the more masculine-oriented world of science? This is where the meld takes place. This is where we start to shake hands with Dave Nichols and Franz Wollenweider and Robin Carhart-Harris and understanding more about the neuroscience and why people are reporting these behaviors. What effects are they having? What might be the cause of those effects? So I hope everyone can see. This is where we step away from the images that are awful fun to work with, but not where we're going now. With the increased sense of well-being and the increased sense of pleasure and stimulation with MDMA, I got a real insight at a conference in London last summer when Dave Nichols made kind of an offhand comment. He said, I don't know why everybody's always going on about serotonin. They're attributing everything to serotonergic effects with MDMA. Serotonin doesn't make you feel good. SSRIs aren't happy pills. I'm paraphrasing Dave. It's really the dopamine. And then I started to think, this is in accord with what we're seeing in the treatment sessions. In the lower doses, it's more of a feeling of, Dorothy on the farm back with Annie M. I always think of Mary Cosimano and Bill Richards when I see that image of Dorothy there back in Kansas. And then it's the dopamine that brings about those real euphoric stimulating effects, and we see that with the higher doses. So similarly, you have oxytocin, increasing bonding behaviors, perhaps improved GABA utilization, bringing more of an inhibitory response, and so you get the idea. So for this study, I'll go very quickly. It's a randomized, double-blinded, placebo-controlled pilot study. The emphasis is on safety and feasibility, with efficacy as our third priority, an N of 12. Another advantage of doing the qualitative interviews prior to developing the protocol was I heard in several interviews that individuals found MDMA to be too stimulating. They preferred other substances. So I thought maybe with people with difficulty with inhibitory response, we might need to consider a lower dose for this population. The standard clinical dose range for neurotypical populations might not be a good fit. So in our first group, we started at 75. If they tolerated that well, escalated to 100. Group 2, 100 up to 125. In an open label, they know the dose, we know the dose. 75 goes up to 125. And I'll say a little bit more about what we've seen so far. Just a few more details about the study. Our primary outcome measure is the Leibowitz Social Anxiety Scale. Dr. Christopher Struble is our blinded independent rater. That's his sole function on this project. As you can imagine, in psychedelic science, we have to find ways to mitigate confirmation bias. And having Dr. Struble come in, administer the LSAS, never discuss the scores with us, and we don't discuss the sessions with him. I'm still blinded, but I won't be by the end of next month. And we have other secondary measures that may have implications for other future research. And there's also a biomarker component to this study. We do blood draws that we will ship up to Stanford. Our participants have to have moderate to severe social anxiety. The autism spectrum is very difficult to define now. And for those who don't know, in May of 2015, all autism diagnoses were consolidated under the one autism spectrum disorder diagnosis. Individuals in our study, some have had a prior assessment and diagnosis, some have not, but everybody completes the ADOS-2 adult module for entry into this study. Everybody needs to be MDMA naive, and in lieu of doing an exhaustive battery of intelligence testing, we require that everyone has completed 2 years of college or the equivalent. A little bit more information about inclusion and exclusion criteria. So what's different about setting when you're working with individuals on the autism spectrum? We've inherited a lot of accrued wisdom about how to set up treatment rooms, but it's different in some key ways. One thing that's really vital if you're ever working in any clinical setting with adults on the spectrum, please don't decorate like a pediatrician's office. That's really annoying for them. So we created a very adult space. And we also have lots of STEM toys. For those who aren't familiar with autism, you may have seen depictions of the stereotype hand flapping and rocking. Those behaviors are self-stimulatory behaviors are a very effective strategy for soothing and hyperarousal. So we have lots of things to fidget with, and I can recommend the website Stimtastic if you want to get your own STEM toys. So how do we prepare for psychotherapy for a population that has not shown to respond to conventional psychotherapy particularly well? I'll emphasize the first 2 points on this slide. It's very important in the beginning to confirm what their communication preferences are and to adapt accordingly. And make the structure of every visit explicit in advance to the extent that you're able. And that will help anyone you're working with on the spectrum feel much more comfortable generally. There are a few other points. A note about the second to the last bullet point of the importance of having a balance between indirect and directive approaches. A lot of the tools I was taught to use as a therapist about asking open-ended questions might lead nowhere in providing therapy for someone on the spectrum. So developing discernment about when it's more appropriate to be a bit more directive than a therapist might ordinarily be is important. So the therapy that we provide for everyone is the core mindfulness module from dialectical behavioral therapy. It was developed for individuals with a borderline personality disorder diagnosis, but this little module is foundational for those training modules that emphasize effectiveness in interpersonal relationships, emotion regulation, and distress tolerance. And I thought that sounds like an awfully good match for the population with whom we are working. It also has an extra benefit. I had a sense that this would be the case, and it's really proven to be so, that having that mindfulness vocabulary facilitates much smoother conversation when someone who is MDMA naive is having that experience for the first time. And when they're in that ineffable place, we still can dialogue effectively. A little more about the treatment sessions. We sort of alternate during sessions between more structured and unstructured periods of time. We do employ the kind of classic music and eye shades model to encourage reflection within, but it's a social anxiety study. So it makes sense to include some practice in social interaction as well, and I'll show you in a minute what that looks like. And in lieu of a hospital stay for this group, we also consent a study support partner who does all the driving on the treatment session day and commits to staying with the study participant for 24 hours after treatment as a compassionate and supportive presence. So when we interact during sessions, what does that look like? We have several tools that have worked very well so far. We sometimes use these cards. I recommend them for any therapists in the room. Working with people who are often very alexithymic, it can be helpful to offer a visual option. And frequently what I'll do is lay out the whole deck of all these emotion cards and prompt them, pick 3 cards that will give us an idea of how you're feeling right now in this moment. And for a population that's been described as emotionless or robot-like, it's very gratifying when I ask them, are there any cards here that you don't relate to at all or have never felt that you've had that emotion? And so far, everyone has said, no, I can relate to all of these emotions. And here's a sampling that was drawn from an actual session. So this is another way for people to let us know that they're doing all right. But I can assure you, the cards drawn are not always this optimistic. When people are working with challenging material, they let us know as well. So another tool we use with our neurodiverse population, we encourage, we invite, we don't force anyone to create a visual diary of the experience. And this is from a session that took place this summer. With permission, I can share some of these images. This individual had placebo and then active MDMA. The images from the placebo session were much more concrete and kind of goal-oriented. I'm going to exercise more, or I'm going to get out and try that thing that I've been too socially anxious to try. But this was from the MDMA session. It began, they came back for open label. At 6 months, we break the blind, and everyone who had placebo is invited back for 2 open label MDMA sessions where we know the dose and they know the dose. So it began very concrete, a depiction of the bowl that we hand when they take the capsules. But the images from this session reflected much more insight. They described how the inner critic was silenced, and that's not a self-portrait, by the way. This individual was consumed with feelings of being a complete loser, that life had passed them by, that there was really no hope for a brighter future. But at the 1 month mark after treatment, they had revised that notion about their life and where it was headed, and now they are a work in progress. I was advised multiple times before I began this work that adults on the spectrum will not work with metaphors or analogies or figurative language. Just leave it out of the room, just be very concrete. I have to tell you, some of the most poetic, beautiful, meaningful, symbolic and figurative imagery has come from this study. This individual had the realization that finding friends, the task ahead for them, was more like panning for gold. Or as we like to say, they're looking for 4 quarters instead of 100 pennies. And here's a reflection of the kind of Asperger's take on this task. This study participant indicated that this was really the most meaningful image for him. He drew out 100 years. I've lopped off the beginning and end so you don't know the age, but drew out 100 years, and that blue line indicates MDMA, and the life before that was very bleak. This individual had to overcome so many hardships. It's really amazing to see where they are now. Looking at this image, they were able to realize how many years ahead were available and how they were now available to write a new story for themselves and live those years quite differently. So there's a lot of talk about integrative psychotherapy. These are some of the techniques that we use. I'm going to speed up a bit. When we're first introducing the core mindfulness skills, we talk about reasonable mind, rational mind, and the intersection where the Venn diagram overlaps, and you have wise mind. One participant, someone else, when invited to draw a depiction of their mental mind map, drew these gears that didn't fit together very well and weren't really connected, but post-treatment, invited to try again, it looked like this. So you can see this is rational mind is the smaller lobe now. Emotional mind is much larger, nice big wise mind encapsulated in an integrated whole. And the connectors kind of remind me of arteries. It kind of reminds me of a liver and some lungs, much more organic. So a little progress update. 12 participants enrolled to date, 10 fully treated, 2 partially treated, 1 dropped after the first treatment session for an entirely non-safety related reason, and 1 is due to come back for a second blinded treatment session at the end of this month. Safety, safety, safety. No serious adverse events. Everyone able to escalate. No evidence of any harm at the interim analysis halfway because it was a feasibility and safety pilot. The sponsor took a look at the data to look for evidence of any harms. There were none, and we were able to continue. We're seeing trends towards positive outcomes. And for those individuals at baseline who presented with depression, we're seeing some acute and lasting antidepressant effects that I believe, combined with results from other studies, will be supportive of future depression studies with MDMA-assisted therapy. Very quickly, no problems with systolic or diastolic blood pressure. No serious adverse events. You can see a brief list there of events that were reported in mild, moderate, and severe categories. All of them were resolved. A little bit of safety data on the types of spontaneously reported reactions from treatment session being day 1 through day 7 of follow-up. Very few reactions reported with a moderate intensity. Few more there. One severe intensity reaction reported, a headache, kept them in bed most of the day after treatment, but resolved a little bit more on moderate intensity reactions after the second treatment session at the higher dose. And then I thought it was important to add, because I'm asked frequently about the dip in mood post-treatment. So here is a breakdown of the mild intensity, low mood reported after sessions 1 and 2. So we're not really seeing severe outbreaks of the Blue Mondays after this treatment by any means. Graphs, data, quantitative. Here's the caveat. Preliminary, preliminary, preliminary. I am making no claims about statistical significance. We have more data to analyze, but this will show you some of the trends. You can see with our state anxiety, our placebo group does better after treatment, and then after follow-up, starts to go up. MDMA group came down, then really dropped down during follow-up. And we've yet to analyze what we know about what was going on in everyone's life during that time to really comprehend what we're seeing here. But it's encouraging. Similarly with trait anxiety, how you generally feel. The MDMA group, anything on state over 40 is kind of considered clinically significant. A drop after the first treatment session, then a plateau, a long steady drop after the second treatment session, and then sustained over time. It's lower. And the N for the placebo group at this point is so small, I don't want to make any bold claims. We'll see when we analyze all the data what that will show. Similarly with perceived stress, the MDMA group had a long steady decline, dropped even further during follow-up. If you can see that band in the middle, that's the band for the normed means for this instrument. And the placebo group, when they were in follow-up, started to go up. Don't know what to make of these findings yet, but it's just nice to look at. This is the Rosenberg self-esteem scale. Our placebo group was slightly above the cutoff for normal healthy self-esteem, but the mean scores for the MDMA group were slightly below. And MDMA group had a nice steady increase, so for whatever reason, both groups are now, the mean scores for both are up near the ceiling of normal healthy self-esteem, so speculating perhaps we found a good challenge to MDMA-assisted therapy in the core mindfulness skills. So this is a very brief preview of a talk that will be developed. This is kind of a preview of coming attractions. I've learned personally so much about psychedelic research from working with a neurodivergent population. It was very humbling to see my own ableism that I was not aware of prior. But there are so many implications going forward, looking to the next 10 years about working with neurodiverse groups, ethnically diverse groups, taking into account sex and gender. The best answer I got to the question about gender at screening was, I'm gender vague. Spiritual and religious diversity. With our group, if I had iconography and imagery from the world's great religious traditions, that might be a big mistake that could result in a breach of the therapeutic rapport. I learned the value of community-based participatory research, going back to the beginning of this talk, advocating for the value of qualitative inquiry to start. One of the absolute critical success factors for this study has been working with a representative from the autism community as a paid consultant. Nick Walker has been responsible for introducing me to a lot of the concepts I touched on today. He has been with the team from inception and has advised us at every step, from protocol development to instrument selection, and he's reviewed everything we've published to make sure that we don't inadvertently do any harms to the autism community. So broadening the questions started raising questions for me about, is psychotherapy an essential element of psychedelic treatment? Two individuals who've been very active in the psychedelic community for quite a long time posed this question to me recently. My knee-jerk response was, well, yes, of course. But working with a neurodivergent population made me examine that assumption. How do we choose the type of psychotherapy? Psychodynamic conventional talk therapy has not been shown to be effective. How do you select an appropriate option? What about issues of access? Having a lot of therapy over a long treatment session, that's expensive. Who will have access? And also the pace of therapy. The 50-minute hour does not fly with autistic adults. You kind of triple the time so that we can communicate effectively. Methods and conventions, like we talk so much about eye shades and headphones. How do deaf individuals respond when they hear us talk about how important music is? What are the boundaries for appropriate touch? We've had individuals for whom both of us grabbing and squeezing tight and a double bear hug was appropriate, and others for whom they're very aversive to touch. What's the scope of competence required when working with diverse populations? What attributes do the therapists need to have? There were a lot of challenges to best practices. You watch the videos of our sessions, and I look like a demonstration video about how to be a bad therapist. You don't start by making nice, warm, connected eye contact. That's where you start. People talk about the importance of the male-female dyad. A colleague who shall remain nameless, but I had a great sense of humor about this, was talking about this great study they worked on years ago, where to manage transference and countertransference, they had all the bases covered, because it was a male and female team, and he was a junior member of the team, all co-facilitating. He said, we had everything. We had the mother and the father and the brother. And I waited, and then he caught himself and had a laugh over it. But we need to explore these topics going forward. Which conventions do we break and why? And finally, it brought up a lot of questions about power, and especially as power is employed in this community. Who decides what is optimal? Who controls the lexicon? Who oversees safety, ethics, and professional standards? And who defines psychedelic? So very briefly, this is what happens when you have a therapist speak. I'm going to invite you to engage in an experiential here. I've worked on 2 psychedelic studies, one with psilocybin, one with MDMA. I have access to lots of quotes. With permission, I'm going to share some with you, but silently to yourself, just as you read the quote, ask yourself, do you think this is an MDMA quote or a psilocybin quote? Okay. Okay, got it? And the giveaway. These were all MDMA. So with that, I'll just encourage you looking forward, keep that open mind that got you here in the first place, and question as we start to solidify our standards and values, make sure that we are flexible enough to include everyone who should be included here. So thank you very much for your time.
Yes. Beautiful. Thank you so much. We're going to do some Q&A.
Can you tell me, were your participants on any other medications at the time, your study?
For this study, they're required to taper for 5 half-lives plus a week. Frequently what we heard was, I've been on this and this and this, or I'm currently taking this, this and that, but it's not really effective for me. I would like to go off for this study. So we've had the minority have tapered at least one prescription medication. A bigger challenge we've had has been self-medicating with daily medical cannabis, and that's been more difficult. But we've had at least one individual report to us that after MDMA treatment, they no longer use cannabis at all. So concurrently during the treatment phase, they can't be on some medications. People can resume taking during the 6-month follow-up, but not when they're in the active treatment period.
What about the use of 5-HTP? 5-HTP.
Yeah, we don't make any particular recommendations about supplements, either pre or post treatment. Sometimes people will ask Dr. Grobe. I'm a psychologist, not a psychiatrist, so I never advise. I refer to Dr. Grobe, and some things like melatonin for sleep, or if they're tapering off other sleep medications, he may approve. It's on a case-by-case basis, but we haven't really considered 5-HTP often in this group.
I'm really sorry about this. I missed the whole lecture. Can you just describe in like 2 words what this was about? Really bad traffic.
It talked about the qualitative foundations and some of the quantitative findings from a social anxiety study for adults on the autism spectrum, a pilot study that's about to conclude.
With the use of MDMA?
Pardon me?
With the use of MDMA?
With MDMA, double-blind, placebo-controlled. We got rather arrogant about the ineffectiveness of the placebo control until we were fooled. So the method works. We don't always know.
All right.
Okay?
Thank you.
Thank you.
Thank you. Thank you.
So one question I had is, my understanding of autism research is that most people say that the earlier treatment is started, often that's the best outcome for the patient. And so there's a big push for early diagnosis and early treatment with these patients. How do you think if MDMA treatment is shown to be effective, would you be willing to go younger into, not children, but younger to try and have a better outcome earlier in life?
I'm asked that frequently, and my answer is, in general, no. I think 18 would be the lower limit, and here's why. At this point in history, MDMA hasn't been studied in the developing brain. But more to the point, from a therapist's perspective, an individual really needs to meet some key developmental milestones towards individuation and developing a sense of agency to know what to do with the tool of MDMA when they pick it up. Our outcomes are much better when someone can articulate an active intention, as opposed to, so often in the beginning they'll say, oh, I don't know, I've never done this, I want to see what it does to me. And oftentimes that's part of the preparatory psychotherapy, to see if they can engage that sense of agency and tap into that wise inner healing intelligence. And I think that most adolescents might find the experience pleasurable, but it may be, in the future, the determination might be like providing therapy for a minor without parental consent if they're mature enough to participate. And I think we'll refine clinical tools to better be able to make that determination going forward.
I know about this more from ethnopharmacology and not so much from psychology, but we're in the unfortunate situation that drug companies don't like to invest in non-patentable chemicals. So how do you see in the future, once this gets FDA approval, there will be an economic model for being able to get this valuable treatment to everyone? Should we start talking to Hillary Healthcare about getting MDMA and psilocybin approved and covered now?
Gosh, it's so hard to talk about this research because the confirmation bias, expectancy bias, self-selection bias is just off the charts. But based on actual hard data I've seen to date, I think there's the potential for these treatments to absolutely challenge the existing paradigms. I probably shouldn't be so self-revealing, but I'm challenged now, transitioning off the study, wondering how I'm going to function as a clinician without this tool for some cases. It's kind of like being a firefighter being told you can't bring your hose to the fire. Not for everyone, but particularly with certain types of trauma or certain challenges where there aren't good options available.
Thank you. Thank you. Another question?
Hi, Alicia. Thank you for a great talk. So actually what you just said sort of segues into my question. I work at McLean with girls with borderline personality disorder, which is a unit that really focuses on DBT. So I'm wondering if you ever, what your perspective is on using this type of treatment with borderline personality disorder.
I'm sorry, I couldn't hear clearly what you said.
Sorry, I tend to talk really fast. Can you hear me now?
Yeah, I'm from California. Slow it down a little.
So I work at McLean with girls with borderline personality disorder, which is a great program that focuses on DBT.
Let's talk.
Yeah, I would love to. So I'm really wondering if you ever see this type of treatment, with girls with borderline or any gender with borderline.
Thank you for asking that question. I was advised by our consultant from the autism community that women on the spectrum are frequently first misdiagnosed with a borderline personality disorder diagnosis, and it's really hard to tease out when you're working with autism where one diagnosis, the DSM, starts not making a whole lot of sense. And just anecdotally, it has been a challenge across teams. We've experienced it on our team without the time or real resources to adequately assess for the more, pardon me if this is an offensive category, but the more access to diagnoses. And we've thought, wow, this was a really challenging case, and compared notes as clinicians, but there's an emerging, just baby burgeoning consensus that individuals with personality disorder diagnoses can change. And once again, a great opportunity to cite Catherine McLean's paper on openness. Really important paper if you haven't read it.
Yes.
They can change. It takes longer, and maybe it's not such a dramatic leap, but I think this is one of the most promising areas for future research with psychedelic-assisted therapies.
I was wondering, because there is a spectrum, what qualified your participants for the study, and do you think that this method of therapy would help the entire spectrum?
Another great, I love the questions in New York. This is exploratory. This is the first study of its kind. I was appalled when I started. What got me going down this road was the question just popped in my head: what happens when people on the autism spectrum take ecstasy? And like a bear trap, I couldn't let go of that until I got some answers. So I am not an autism expert. I'm a psychedelics clinical researcher. And so I came with kind of a fresh perspective with no advocacy agenda behind me. And so I wanted to answer the same question you're answering. For feasibility and safety and logistics, we started with the range of individuals who, for the most part, would have already had or would have the old Asperger's diagnosis, but not everyone in our study. And the outcomes, there's a qualitative difference. So anybody out here who has aspirations to take the next step and slice off a piece of this question and do more research, we're working with that lost generation. I don't know if the audience is aware, the term Asperger's didn't appear in English language medical literature until about 1981. So there's a whole kind of lost generation of misdiagnosed, underdiagnosed, never sought assessment. So we have a lot to explore there still. Did I answer the question for you? Okay.
You did, thank you. So please join me in thanking Alicia Danforth. Yes.
Thank you.
Alicia.